Surgical and Endoscopic Treatment of Obesity. Shelby Sullivan, Stephen A. Edmundowes, John Magana Morton. 8. Severe obesity is the leading public health crisis of the industrialized world, see Chapter 7. The prevalence of obesity in the USA continues to rise at an alarming rate, with 2/3 of adults currently considered overweight, half of whom are obese. 1,2 The etiology of obesity is complex and only partially understood. Genetic, epigenetic, environmental, and psychological factors are all involved to varying degrees, but, conceptually, obesity is a disorder of energy imbalance wherein there is an increase in stored fat such that it compromises the patient's organ function, susceptibility to disease, and general health. Obesity has been shown to predispose to many diseases, including cardiovascular disease, diabetes mellitus, sleep apnea, and osteoarthritis, see Chapter 7. Overweight is defined by a BMI greater than 25 kg/m2, Class I obesity, 30 to 34.9 kg/m2, Class II obesity 35 to 39.9 kg/m2, Class III obesity greater than or equal to 40 kg/m2, and supermorbid obesity, greater than 50 kg/m2. Rising rates of obesity are seen across the USA in men and women, and in all major racial, ethnic, and socio-economic groups. 3,4 Severe obesity reduces life expectancy by 5 to 20 years, and for the first time in history, it is predicted that the current generation may have a shorter life expectancy than the last. 5 Energy intake and expenditure are finely regulated by neural and hormonal mechanisms. Key players in energy regulation include insulin, leptin, ghrelin, and peptide YY. Insulin is a potent anabolic hormone with multiple synthetic and growth-promoting effects. Adipose cells secrete leptin, which reduces food intake and increases energy expenditure. Leptin's counterpart, ghrelin, is secreted by the fundus of the stomach and induces hunger while stimulating anabolism. Endocrine cells in the ileum and colon secrete peptide YY postprandially, and it is considered a signal of satiety. Obesity is a complex disease with an array of root causes that vary for each patient. Weight loss may be achieved by behavioral, medical, endoscopic, and surgical methods. Combined with careful screening assessments and counseling, however, bariatric surgery is the most efficacious therapeutic option for an appropriate patient population. 6 Weight loss surgery has changed significantly since its inception in the 1950s. Today, with increased efforts by the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery's new Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, MSAQIP, to develop evidence-based recommendations, weight loss surgery has mortality rates comparable to routine general surgical procedures such as laparoscopic cholecystectomy or fundoplication. 7,8 Experience of the surgeon and hospital can mitigate the risks associated with weight loss surgery. In the USA, a volume outcome effect has been recognized by the MSAQIP and major insurers who require MSAQIP accreditation. 9,10 Numerous criteria enable bariatric surgery accreditation, but the primary current criteria are a surgeon's volume of greater than 25 cases and an annual hospital volume of greater than 50 stapled cases. The best demonstrated and most protective effect against complications is an accredited experienced surgeon and hospital. 9,11-14 Roux-en-Y gastric bypass, RYGB. Surgery induces sustained weight loss by altering metabolic processes through fundamental changes in appetite, energy regulation, satiety, and metabolism. Long-term follow-up studies have shown that RYGB positively affects patients' overall health by reversing some of the metabolic consequences of morbid obesity. RYGB is capable of reducing mortality by improving lipid levels, diabetes, hypertension, obstructive sleep apnea, and cardiovascular events such as myocardial infarction up to 12 years after the procedure and beyond 15. It has been shown that bariatric surgery is superior to medical therapy for weight loss, survival, and treatment of comorbidities. 16 The number of weight loss operations is currently greater than 220,000 procedures annually, with laparoscopic sleeve gastrectomy being the most. Commonly performed procedure. Point 17. The following discussion will include indications for surgery, preoperative evaluation, surgical techniques, outcomes, and peri- and postoperative complications. Evaluation and selection of bariatric surgery candidates. To qualify for bariatric surgery, patients must meet the 1991 NIH consensus criteria, which include having a BMI of 40 kg/m2 or greater or a BMI of 35 kg/m2 or greater with obesity-related comorbidities and at least 6 months of documented medically supervised weight loss attempts. Point 18. Given recent data, there are efforts to extend indications to include a BMI 30 to 35 kg/m2 for patients with diabetes. Point 19. Obesity-related comorbidities include hypertension, diabetes mellitus, hyperlipidemia, GERD, arthritis, IBS, obstructive sleep apnea, and NASH. Substantial preoperative evaluation should attempt to discover potential occult comorbidities like coronary artery disease, sleep apnea, and obesity hypoventilation syndrome, Pickwickian syndrome. Because of the complexity of the preoperative evaluation, a multidisciplinary approach is necessary. The team should include a nutritionist, psychologists, anesthesiologists, bariatric surgeons, and other subspecialists that can address any gastroenterologic, cardiovascular, pulmonary, or endocrine-related issues. Family and social support should not be underestimated and also are an integral part of the team. Point 20. Additionally, patient education is paramount to successful outcomes after bariatric surgery. Educational sessions are mandatory with dietitians, specialized nurses, and the bariatric surgeon detailing pre- and post-operative diet and lifestyle modifications, as well as preparing patients for what to expect after surgery. Some bariatric surgeons require patients to lose additional weight through diet and exercise between the time of the initial bariatric surgery consultation and the date of operation, particularly for patients with a risk of weight regain. Point 21. Preoperative weight loss is a method for downstaging, in a fashion analogous to preoperative chemoradiation therapy for cancer. This additional required preoperative weight loss is not correlated with comorbidity resolution or complication rates. Point 21,22. However, it is associated with shorter operative times, a smaller liver, and greater weight loss at 1 year after the surgery. Therefore, preoperative weight loss may be encouraged in all patients while balancing access to care so there is not a delay in treatment. Point 21. Bariatric surgery candidates, in particular, benefit from preoperative nutrition evaluation and counseling. After surgery, patients are instructed to consume a progression of diets that start with full liquid, followed by pureed soft foods, and finally include regular textured foods. Patients should also be reminded that bariatric surgery is a restrictive procedure, and therefore smaller, more frequent meals are most appropriate. Point 23. Contraindications to bariatric surgery include psychiatric conditions such as schizophrenia, severe bipolar disorder, active substance abuse, recent major depression with hospitalization or suicide attempts, and developmental delay. Other contraindications include severe cardiac disease that would prohibit safe and effective anesthesia, severe coagulopathy, or inability to comply with rigorous postoperative nutritional requirements including lifelong vitamin replacement. Age is not an absolute contraindication in patients with severe comorbidities, and bariatric surgery is performed in patients older than age 65 or younger than age 18.24. Prior to surgery, patients should complete a screening process, including consultation with a surgeon, psychological evaluation, nutrition consultation, chest röntgenogram, electrocardiogram, and EGD. A preoperative EGD is recommended by the European Association for Endoscopic Surgery to detect and treat any upper GI lesions that may cause postoperative complications or influence the decision of which type of bariatric surgery should be performed. Point 25. In a study of 272 gastric bypass patients who underwent preoperative EGD, 12% of patients had clinically significant preoperative findings that included erosive esophagitis, 3.7%, Barrett esophagus, 3.7%, gastric ulcer, 2.9%, erosive gastritis, 1.8%, duodenal ulcer, 0.7%, and gastric carcinoid, 0.3%. 1.1% had more than one lesion. Given that 12% of the patients who eventually underwent RYGB had clinically significant preoperative findings but that 2/3 of these patients had UGI symptoms, it is important to perform EGD preoperatively because the excluded distal stomach cannot be evaluated easily after a RYGB procedure. Point 26. In addition, preoperative screening for GERD is critical prior to a laparoscopic sleeve gastrectomy given that the greatest risk for postoperative GERD is preoperative GERD. Findings of severe reflux may guide the surgeon and patient alike in a procedure choice. Point 27. Medical evaluations of cardiovascular disease, respiratory illness, and diabetes should be completed prior to surgery. Cardiovascular evaluation should include a recent history of chest pain and assessment of exercise tolerance. Patients with multiple risk factors such as a history of DVT or venous stasis disease may require temporary inferior vena cava filter placement prior to surgery to prevent venous thromboembolism. Point 28. It is also important to identify occult obstructive sleep apnea so that the anesthesiologist may anticipate periods of hypoxia in the immediate postoperative period when it may be compounded by narcotic pain medications and postoperative fluid shifts. Point 29. Additionally, diabetes must be well controlled preoperatively to reduce the incidence of perioperative morbidity, e.g., wound infection. Point 29. Surgical treatments for obesity. Gastric bypass. After gastric bypass, both restrictive and hormonal mechanisms limit food intake and nutrient absorption. First performed by Mason and ITO in 1966, gastric bypass has since been modified twice, once in 1967 to incorporate a roux limb rather than a loop gastrojejunostomy, and again in 1994 to be a primarily laparoscopic procedure. Point 30. The laparoscopic approach is superior to the open approach and has considerably lower complication rates. Laparoscopic gastric bypass has reduced mortality rates and lowered rates of wound infection, pulmonary and thromboembolic complications, and incisional hernias, and has decreased the average hospitalization time to about 2 days. 31. There are many variations of laparoscopic RYGB techniques, but essential components include construction of a gastric pouch, attaching the pouch to the jejunum, and rerouting digestive enzymes such that they do not contact food until it reaches the jejunostomy. Fig 8.1a. Point 8. At the time of surgery, care is taken to position the patient appropriately so as to facilitate intubation and prevent nerve compression and skin breakdown. To prevent postoperative nausea and vomiting, several strategies are employed, including hydration and small doses of glucocorticoid and ondansetron. An orogastric tube is placed to prevent gastric distension or aspiration. Prophylactic subcutaneous heparin, 5,000 units, sequential compression devices, and cefoxitin, 2 grams 4, should be administered prior to incision. In the operating room, endoscopes to enable evaluation of the stomach and deep intestine should be available. Surgery is begun by placing an index trocar at 18 cm below the xiphoid in the midline after the Veress needle has been introduced to establish pneumoperitoneum. After remaining trocars are placed, laparoscopic exploration of the abdomen is conducted. The greater omentum is elevated, and the ligament of Treitz is identified. The jejunum is divided into biliopancreatic and roux limbs at 20 cm distal to the ligament of Treitz. Next, the jejunostomy is performed after a 75 to 150 cm roux limb is passed toward the proximal gastric pouch, either through the transverse mesocolon, retrocolic, or in front of the colon, anticolic. The retrocolic method may either take a retrogastric or antigastric route. Any mesenteric defects between loops of bowel are potential hernia sites and, therefore, are closed with permanent running suture. The gastric pouch should be between 15 ml and 30 ml in size and is constructed based on the size of the lesser gastric curve. Finally, the gastrojejunostomy is constructed either through circular stapled, linear stapled, or hand-sewn techniques, and a surgical drain may be placed. Potential pitfalls of the procedure include bleeding, inability of the roux limb to reach the gastric pouch without tension, and unexpected anatomy such as malrotation, enlarged liver, excessive omentum, or thick abdominal wall. Though rare, Unexpected findings during a laparoscopic gastric bypass may influence the Chapter 8 surgical and endoscopic treatment of obesity 103-8 operative course. These findings could include tenacious adhesions from previous surgery that require lysis, malrotation of the ligament of Treitz necessitating a mirror image approach to the technique, hernia findings that require a change in port placement, or a cirrhotic appearing liver that may require biopsy or even aborting the case if varices or ascites is noted. A cyst that may not have been revealed with preoperative assessment may be resected in its entirety and the surgery completed as originally planned. Sleeve gastrectomy. The vertical sleeve gastrectomy, SG, see Fig 8.1e, involves removing about 80% of the stomach, with the resultant remaining sleeve that is lesser curve-based and is 28 to 32 French, fr, in diameter. It has been hypothesized that the tighter the sleeve, the more likely the possibility of a leak, which is the most common major complication after SG. Other potential pitfalls may include bleeding or strictures. Care should be used while taking down the blood supply to the greater curvature of the stomach. An advanced bipolar cutting device or ultrasonic scalpel is used to seal the blood vessels. At the most proximal portion of the stomach, the short gastric vessels can be in close proximity to the spleen, and the surgeon must avoid excessive traction in this area to avoid a shear injury. A bougie, 32 to 40 fr, is used to guide the staple line along the sleeve. A tight sleeve, especially at the incisura, can lead to outflow obstruction and predispose to a more proximal leak. Many surgeons perform an intraoperative leak test with either air or methylene blue to evaluate the staple line. If the leak test is positive, then the staple line can be reinforced or oversewn in the areas of concern. Patients are placed in the supine or split leg position. 5 trocars are used and placed at the surgeon's preference. The liver is then retracted to expose the stomach including the gastroesophageal junction. The gastrocolic ligament is then divided, and the vessels of the gastroepiploic arcade are cut using an advanced bipolar cutting device or the ultrasonic scalpel. Dissection is carried out along the greater curve of the stomach from 3 to 7 cm proximal to the pylorus up to the angle of His. The stomach is then freed from any posterior attachments within the lesser sac. Care should be taken to avoid injuring the splenic vein and artery during the dissection. A bougie, 32 to 40 fr, or endoscope is then passed into the stomach as a guide for stapling. The sleeve is then created with multiple staple loads from just proximal to the pylorus to the angle of His. The stomach should not Fig 8.1 types of weight loss operations. A. Roux-en-Y gastric bypass. B. Gastric sleeve. C. Vertical banded gastroplasty. D. Laparoscopic adjustable gastric band. E. Biliopancreatic diversion with duodenal switch. AC from the American Society for Bariatric Surgery. The Story of Surgery for Obesity, 2005. Available at https://asms.org. ACEBD 104 Part 2 Nutrition in gastroenterology. Be divided too close to the incisura to avoid stricture at this area. Additionally, when stapling, the surgeon should ensure that the anterior and posterior edges are the same distance from the lesser curve so that the sleeve does not kink or twist. Techniques vary in that some surgeons may use buttressing material within their staples. Surgeons may also oversew the staple line or reproximate the omentum to the new greater curve with interrupted sutures. Drains may be placed at the time of surgery depending on surgeon preference. The patient is admitted for 1 to 2 days postoperatively and started on a liquid diet. An UGI is performed on postoperative day 1 at some institutions to show free passage of contrast through the sleeve without evidence of extravasation. The patient is given a PPI for 6 months postoperatively as well as multivitamins to be taken for life. Diet is slowly advanced over 8 weeks as an outpatient from full liquids to pureed food to soft food and finally to a regular diet. Other operations include gastric banding, GBC Fig 8.1b to c. GB has declined precipitously as a result of lack of significant treatment effect and need for reoperation. 32 The GB technique involves a pars flaccida or hepatogastric ligament technique whereby a soft, inflatable silicone gastric band is placed immediately below the lower esophageal sphincter as demarcated by the esophageal fat pad. Biliopancreatic diversion, BPD, with duodenal switch, DS, now accounts for less than 1% of bariatric procedures, see Fig 8.1d. Surgical complications. The average 30-day mortality rate is 0.2% for gastric bypass, 0.14% for vertical SG, and 0.02% for GB. 33 complications can be divided into three categories: intraoperative, early postoperative, within 30 days of surgery, and late postoperative, greater than 30 days after surgery. Significant progress has been made to monitor outcomes and develop evidence-based guidelines of criteria and benchmarks that determine safe practices. As mentioned, complication rates are directly related to the experience of the surgeon and hospital. Complications of bariatric procedures include anastomotic leak or stenosis, pulmonary embolus, PE, and DVT, GI bleeding, nutritional deficiencies, wound complications, bowel obstructions, ulcers, hernias, and respiratory and cardiovascular complications. Among the different surgical procedures, the complication rates are proportional to the amount of weight loss produced by each operation. The odds of serious adverse events at 1 year are, SG, odds ratio, or, equals 3.22, 95% confidence interval, CI, 2.64 to 3.92, RYGB, or equals 4.92, 95% CI, 4.38 to 5.54, BPD plus DS, or equals 17.47, 95% CI, 14.19 to 1.52.34. Bowel ischemia may result from a twisted roux limb or internal herniation that occurred during division of the mesentery. 35 signs of intestinal ischemia are severe abdominal pain, hematochezia, and an acute abdomen. Early postoperative complications are anastomotic leaks, pulmonary and cardiovascular complications including DVT and PE, and mortality. Anastomotic, gastric pouch, or duodenal leakage occurs with 2.2% of RYGB, 1.0% of vertical banded gastroplasty, VBG, and 1.8% of BPD. 33 Anastomotic leak, most commonly from the gastrojejunostomy or from the SG staple line, usually near the hiatus, is an independent risk factor for mortality. 36 It has been demonstrated that a surgeon's experience has significant influence on the leakage rate, with a rate of 1% to 2% in experienced hands and up to 5% for surgeons earlier in their careers. 37 Leaks from SG occur infrequently but can be troublesome to treat. Drainage of leaks along with 4 antibiotic therapy is first-line therapy. Additional considerations include stent placement and enteral feeding. In complex, chronic leaks, definitive therapy may require reoperation, converting an SG to a Roux-en-Y esophagojejunostomy. 38 PE can account for 50% of deaths in the perioperative period. 31 Currently, a combination of anticoagulants and sequential compression devices are used for PE prophylaxis. For patients who are at the highest risk for DVT or PE, including those who have a history of a venous thrombotic event, venous stasis, poor ambulation, pulmonary hypertension, severe sleep apnea, or BMI greater than 60 kg/m2, an inferior vena cava filter may be temporarily placed preoperatively and has been shown to decrease the risk of PE from 2.94% to 0.63% in a series of 330 patients with such high risk factors. 31 Cardiovascular complications such as myocardial infarction are also a significant cause of death in the early postoperative period. For this reason, it is important to perform a careful preoperative cardiac evaluation and involve a cardiologist for high-risk patients. Pulmonary complications are more likely in male patients, those older than age 50 years, Medicare patients, or those with chronic lung disease. 13 Persistent vomiting from stomal stenosis increases the risk of aspiration pneumonia or thiamine deficiency. After laparoscopic bariatric surgery, atelectasis can occur at a rate of 8.4%, and, therefore, Postoperative early ambulation is essential. 35 Late postoperative complications include anastomotic stricture, gallstone formation, nutritional deficiencies, bowel obstruction, intussusception, marginal ulcers or ulcers in the remnant stomach and duodenum, fistula, dumping syndrome, and hypoglycemia. Stenosis of the gastrojejunostomy has been reported in 2% to 14% of patients. Stenosis often manifests 4 to 6 weeks postoperatively as vomiting and progressive food intolerance, first to solids and subsequently to liquids. 39 A high incidence of gallstone formation has been well documented when morbidly obese patients undergo rapid surgically induced weight loss 40 and is due to increased cholesterol delivery to the gallbladder, NIDK. Dieting and gallstones 2017. https://www.nidk.nih.gov/health-information/digestive diseases/gallstones/dieting. Accessed April 4, 2019. Cholelithiasis develops in up to 38% of patients after RYGB. If a patient has gallstones preoperatively, the surgeon may elect to perform a concomitant cholecystectomy. This is less commonly performed with the laparoscopic approach because it is easier to do by open technique than laparoscopic. 41 Gallstone formation occurs secondary to a combination of vagus nerve damage, altered enteric nerve stimulation, decreased gallbladder emptying, and changes in calcium concentration and the bile salt/cholesterol ratio. 35 It has been shown in a double-blind randomized placebo-controlled trial that ursodeol at a daily dose of 600 mg for the first 6 months after surgery reduces the incidence of gallstones to 2%. 42 To reduce the incidence of cholelithiasis, a 6-month course of ursodeol is recommended for patients whose gallbladder is not removed prophylactically. 42 Nutritional deficiencies can be extensive, related to both the changes in anatomy and postoperative sequelae like persistent vomiting. Bowel obstruction occurs in 0.2% to 7% of RYGB patients, the range varies depending on the surgical technique. For example, if the roux limb is passed in a retrocolic fashion, there are 3 potential hernia sites, mesocolic, jejunal, and between the colon and roux limb. 20 Most bowel obstructions develop 6 to 24 months postoperatively, but they can occur earlier because of technical errors related to mesenteric defects. Bowel obstructions that occur early usually require bowel resection to prevent retrograde distension of the biliopancreatic limb and distal stomach, which could result in rupture of the distal gastric staple line and consequent peritonitis. 20 In later bowel obstructions, surgical intervention is only required after failure of NG decompression, for fluid resuscitation, and NPO status. When intussusception occurs, it is usually years after surgery. Patients with the highest risk of developing intussusception are those who have lost more than 90% of their excess weight. 35 Chapter 8 Surgical and endoscopic treatment of obesity. 105 8 Marginal ulcers are ulcers located in the jejunum near the anastomotic site. They are estimated to occur in 1% to 16% of gastric bypass patients. 43,44 Perforated marginal ulcers occur in 1% of RYGB patients. Ulcer perforation is linked to smoking and use of NSAIDs or glucocorticoids. 45 The use of non-absorbable sutures, as opposed to absorbable sutures, for the inner layer of the gastrojejunal anastomosis, GJA, is associated with increased ulcer incidence. 46 The presence of HP also increases risk for marginal ulcers. 47 It is common practice for bariatric surgeons to use PPI therapy for 6 months postoperatively. If a marginal ulcer is recalcitrant to medical therapy, the possibility of a gastric fistula must be entertained, for which surgical correction is mandated. The remnant stomach maintains a pH of 2 to 3 and still responds to vagal and hormonal stimulation, therefore, ulcers may also occur in the gastric remnant and duodenum years after surgery and independent of HP status. Endoscopic evaluation of the gastric pouch is challenging given the divided stomach, thus, unstable patients may require surgical exploration. 35 Fistulas occur rarely, and often concurrently with a marginal ulcer. 35 They form most commonly between the gastric pouch and gastric remnant, and are due to a GI leak from the gastric pouch eroding into the gastric remnant. 48 Large, Undiagnosed gastrogastric fistulas may result in weight regain. 20 fistulas leading to weight regain require elective endoscopic or surgical repair. Dumping syndrome can occur in up to 20% of RYGB patients. 49. It is classified as early or late depending on how soon it develops after a meal. Early dumping ensues 15 to 30 minutes after eating and is thought to be due to the rapid entry of hyperosmotic foods into the jejunum. It is due to rapid fluid shifts into the intestinal lumen with a meal, which results in a parasympathetic response leading to a reduction in systemic vascular resistance, an effect called splanchnic blood pooling. 149 symptoms include cramping, abdominal pain, voluminous diarrhea, bloating, dizziness, nausea, flushing, and tachycardia. Symptoms result from hypovolemia and a subsequent sympathetic response. 35 Dumping syndrome is triggered by consumption of simple sugars, acidic foods, and nutrient-rich drinks such as Gatorade. 49 Foods high in protein and fiber should be consumed to avoid this uncomfortable syndrome. Additional behavior modifications include smaller, frequent meals, lying down after meals, and avoidance of very hot and very cold foods. 20 to reduce symptoms related to decreased systemic vascular resistance. Early dumping is usually self-limited and resolves between 7 and 12 weeks after surgery. Late dumping syndrome occurs 2 to 3 hours after a meal and is secondary to rapid glucose absorption, subsequent hyperglycemia, and release of glucagon-like peptide 1 and gastric inhibitory polypeptide. A relatively exaggerated insulin response ensues, leading to hypoglycemia and hypokalemia. Patients present with diaphoresis, weakness, fatigue, and dizziness. 49 The same modifications suggested for early dumping syndrome should also ameliorate the symptoms of late dumping syndrome. 35 Treatment includes dietary and medical interventions to control serum glucose levels. 35 GI bleeding can occur postoperatively in 2.0% of RYGB, 0.7% of VBG, 0.3% of laparoscopic adjustable gastric banding, LAGB, surgery, and 0.2% of BPD. In RYGB patients, postoperative dysphagia is not significantly worse than the patient's matched preoperative symptoms and can develop with food indiscretion, stricture formation, or other obstructions. 50 Beyond the type of procedure, there are identified risk factors for complications after bariatric surgery, including older age, male gender, greater BMI, comorbidities, and Medicare insurance status. 51-53 The increased risk for Medicare patients is beyond age, because eligibility for Medicare is disability, which may affect outcome. Although patients with the greatest number of risk factors carry the highest risk for surgery, they also may derive the most benefit from bariatric surgery, given the disease burden they carry. 14 Of note, complications may not affect long-term weight loss, which is the outcome that best predicts long-term mortality risk. 21 Nutritional deficiencies. Nutritional and vitamin deficiencies and electrolyte abnormalities occur in 16.9% of RYGB patients. 33 Patients who do not take daily vitamins postoperatively or patients who experience frequent vomiting are at increased risk of developing such deficiencies, most common of which are protein, iron, vitamin B12, folate, calcium, and the fat-soluble vitamins A, D, E, and K. 54 Prolonged vomiting may result in thiamine, vitamin B1, deficiency, which can lead to Wernicke encephalopathy, a syndrome of confusion, ataxia, ophthalmoplegia, and impaired short-term memory. See Chapter 103. This neurologic deficit is preventable with appropriate administration of thiamine. If thiamine deficiency is suspected, the patient should be given 4 or intramuscular thiamine immediately to increase the chances of symptom resolution. 55 Early treatment is imperative because persistent severe symptoms may not be reversible despite delayed administration of thiamine. The parietal cells of the stomach produce intrinsic factor, IF, which is necessary for vitamin B12 absorption in the terminal ileum. See Chapter 103. Patients who undergo RYGB may develop B12 deficiency because RYGB separates the parietal cells in the fundus of the stomach from the smaller gastric pouch. There is, therefore, no contact between ingested food and IF until the intersection of the roux limb in the jejunum. 56-57 In addition, the parietal cells of the stomach often cease to produce if after RYGB, presumably because the fundus no longer has any contact with food. 58 Restrictive bariatric surgery does not cause vitamin B12 deficiency because the parietal cells in the fundus of the stomach remain in contact with the nutritive stream. 59 Calcium, iron, and folate deficiency can occur because they are absorbed mainly in the duodenum and proximal jejunum. These segments of the digestive tract are commonly bypassed in gastric bypass surgery. Moreover, vitamin D is necessary for calcium absorption, and vitamin D deficiency further contributes to any calcium deficiency. 54 Outcomes. The steep rise in bariatric surgery utilization can be attributed to its proved efficacy as a treatment for morbid obesity. Two meta-analyses have provided strong validation that bariatric surgery leads to successful weight loss and mortality reduction. 33 A meta-analysis by Buchwald that included 22,094 patients found the mean percentage of excess weight loss for all patients to be 61.2%. 6 Excess weight loss was highest for BPD with DS, 70.1%, followed by VBG, 68.2%, RYGB, 61.6%, and lowest for LAGB, 47.5%. A meta-analysis by Maggard found similar weight loss trends at 3 or more years post-operatively, with the greatest weight loss achieved after the malabsorptive procedures of BPD, 53 kg, and RYGB, 42 kg, and less weight loss after the restrictive LAGB, 35 kg, and gastroplasty, 32 kg. 633 Such substantial weight loss is associated with a clear reduction in long-term mortality. A retrospective cohort study of 9,949 RYGB patients matched to 9,628 severely obese controls found that having RYGB surgery reduced the adjusted long-term mortality from any cause of death by 40%. 60 Among RYGB patients, mortality was decreased from coronary artery disease by 56%, from diabetes by 92%, and from cancer by 60%. In another study there was a 14% decrease in cancer incidence among patients who underwent RYGB. The biggest reductions in cancer incidence were seen among types of cancers that are considered obesity-related: esophageal adenocarcinomas, 2% reduction, 106 Part 2 Nutrition in gastroenterology. Colorectal, 30% reduction, postmenopausal breast, 4%, uterine corpus, 78%, non-Hodgkin lymphoma, 27%, and multiple myeloma, 54%. 61 The lower cancer risk of patients after RYGB is presumably due to weight loss, which has been shown in many studies to reduce cancer incidence. Furthermore, once obese patients lose weight, they may have easier access to needed health surveillance like Pap smears and colonoscopy. Finally, given that increased BMI leads to worse surgical oncologic outcomes, it may be surmised that with weight loss, a better surgical outcome may be anticipated. Overall, bariatric surgery dramatically improves survival and decreases mortality from all disease-related causes of death. Only the rate of deaths not caused by disease, e.g., deaths resulting from accidents and suicide, increased after bariatric surgery and were 58% higher in RYGB patients. 61 Speculation as to why accidents and suicides were higher in the surgical group was the possibility of alcohol abuse. One study demonstrated altered alcohol metabolism after gastric bypass surgery, perhaps explaining a propensity for alcohol abuse. 62 A recent analysis found that due to increased rate of absorption of alcohol after RYGB, there was both an earlier and higher blood alcohol concentration. This concentration was high enough to be defined as a binge drinking episode, which is a risk factor for developing alcohol abuse. 63 One study of bariatric surgery candidates found that 9% reported suicide attempts and 19% reported alcohol abuse preoperatively. 40 There is concern that this vulnerable patient population has additional difficulty with the psychological adjustments to weight loss, which further supports the need for psychologic counseling before and after surgery. 64,65 In addition to benefiting from decreased mortality, bariatric patients benefit from decreased morbidity. Morbidly obese patients suffer from more intense GI symptoms such as abdominal pain, heartburn, and sleep disturbances than do normal weight patients. Beyond the significant improvement in cardiac risk factors, weight loss surgery also provides enormous benefit for the many medical problems obesity causes. The reduction in GERD symptoms leads to significantly decreased medication use postoperatively for both PPIs, 44% to 9%, and H2RAS, 60% to 10%. In fact, GERD resolution rates following RYGB are so robust that RYGB is a suggested treatment for recalcitrant GERD in morbidly obese patients. 50 Recently, a number of clinical trials have demonstrated a dramatic effect of bariatric surgery on glycemic control in patients with type 2 diabetes, such that the need for medical therapy was decreased or eliminated. Moreover, in a prospective non-randomized case-matched Swedish trial, type 2 diabetes was significantly less likely to develop in obese participants who underwent a bariatric procedure than in their control counterparts. 66 Although this is not an indication that bariatric surgery should be used for the purpose of preventing development of type 2 diabetes in obese patients, nor serve as a replacement for medical therapy, it does suggest that the mechanisms by which bariatric surgery prevents progression from abnormalities in glucose metabolism to frank diabetes is an area that should be explored further. 66 The effects of obesity are not merely physiologic. Administration of the SF36 survey shows that quality of life improves greatly after RYGB surgery. Preoperatively, morbidly obese patients score significantly lower than USA population norms in the categories of general health, vitality, physical functioning, bodily pain, and emotional and social functioning. As early as 3 months after RYGB, these same patients score no differently than USA norms in these categories. 67 As bariatric surgery continues to grow, there is increasing recognition that obesity is a chronic and complex disease. As such, there likely will be variations to current therapy, gastric bypass being the most consistent across surgeons. 68 With such variation, there will be the potential for revision of previous surgeries. In fact, revisional surgery now accounts for 15% of total bariatric surgery. Current evaluation of revisional bariatric surgery outcomes indicates that morbidity is low and weight loss is adequate. However, revisional bariatric surgery morbidity is higher and weight loss is lower than morbidity with primary bariatric surgery. 69 Endoscopic management of bariatric surgical complications. Bariatric surgery is an effective means of treating obesity and its metabolic comorbidities, but these procedures are associated with significant complications that gastroenterologists must be able to recognize and address. Endoscopy plays a critical role in the diagnosis and management of many of these complications. Ulceration at the gastrojejunal anastomosis, GJA, is a common late complication of RYGB. Incidence has varied widely in the literature, but a recent systematic review and administrative database study report incidence rates of 4.6% to 6.28% of patients, Fig 8.2. 0.70,71 GJA ulceration often develops in the first 3 months postoperatively but can occur at any time. Data from an administrative database showed an increase in the rate of surgical intervention for marginal ulceration over time from 6% at 1 year to 17% at 8 years, suggesting a higher morbidity from marginal ulcerations that occur many years later. 70 Patients typically present with epigastric pain, nausea, vomiting, food intolerance, overt or occult bleeding. However, up to 61% of patients are asymptomatic. 43 Moreover, ulcers can occur at any of the anastomoses created during a RYGB. Fig 8.2a, anastomotic ulcer. B. Jejunal ulcer. Images courtesy Christopher C. Thompson, M.D. ABDOWNFLOORAPDERDSFONRAREDDYOSANDEEPO, OLUSENLY. NOT Chapter 8 Surgical and Endoscopic Treatment of Obesity 107 8 Anastomotic ulcers may be due to small amounts of acid produced by the gastric pouch, ischemia, bile acid reflux, HP infection, NSAIDS, smoking, alcohol, foreign bodies such as non-absorbable sutures or staples, or tension on the roux limb. 46,72-76 Gastrogastric fistula and staple line disruption also may result in ulceration from exposure to acid. Evaluation for anastomotic ulceration may be performed with water-soluble contrast media, e.g., gastrographin, or careful endoscopy any time after surgery. Endoscopic evaluation should include the gastric pouch, GJA, and proximal roux limb. This may be accomplished with a pediatric colonoscope, however a deep enteroscopy system is often necessary to reach the duodenum and excluded stomach. Size, depth, and potential etiologic factors should be noted for each ulcer. HP fecal antigen testing may be the easiest and most accurate way to confirm the presence of HP.77. Treatment of ulceration is multifaceted. In patients with RYGB, anastomotic ulcers should be treated with soluble PPI or capsules that are broken open, taken twice daily, and tapered over 6 months. 78 Sucralfate solution at 1 gram 4 times daily should be used concurrently when possible. The tablet form of PPI does not appear to be as effective. Bile reflux can be treated with bile acid binders such as cholestyramine or cholestyramine. Smoking cessation is critical. Control of diabetes should be optimized. NSAIDs should be discontinued, if possible, or combined with PPI or PGE1 therapy if needed long-term. HP should be treated if active infection is found. Visible sutures or staples within the ulcer should be removed. Repeat upper endoscopy to check for healing is recommended at 2 to 3 months after initiation of medical therapy. If the ulcer fails to heal with maximal medical therapy, surgical revision has been the traditional next step in therapy. 70,79 Endoscopic therapy using an endoscopic suturing system to oversew and cover the ulceration has also been reported in a limited case series. 80 Postoperative gastrointestinal bleeding. The incidence and type of GI bleeding after bariatric surgery is typically related to the type of surgery. UGI bleeding after bariatric surgery occurs more commonly after RYGB, 1.5% to 3.5% of cases 81-83, than after LAGB, SG, and VBG. Bleeding can occur at multiple sites, including the pouch, anastomosis, staple lines, contiguous small intestine, excluded stomach, or bypassed small intestine. Additionally, patients can develop esophagitis with subsequent hemorrhage after bariatric surgery due to the altered anatomy. Early bleeding usually occurs within 24 hours postoperatively at the staple lines of the GJA, gastric remnant, or jejunal anastomosis. 82,84 A significant proportion of early bleeding can be extraluminal, and this should be considered if melena or hematemesis is not apparent. These patients may develop hemodynamic instability, oliguria, and abdominal distension without overt signs of GI blood loss. Late bleeding is often secondary to anastomotic ulceration. However, other sites of GI blood loss should also be considered, including the remnant stomach. 85 The esophagus, gastric pouch, and GJA are easily accessed with a standard upper endoscope. Bleeding in the excluded stomach or at the jejunal anastomosis presents a more significant challenge. In these cases, device-assisted enteroscopy may be required. In cases of early bleeding, endoscopy carries a greater risk of perforation due to the immaturity of anastomosis and staple lines. If early endoscopy is performed, air insufflation should be minimized, or CO2 insufflation should be used. Endoscopic therapy of bleeding is highly effective. As an alternative to thermal therapies, endoclips can be used in conjunction with epinephrine injection to minimize tissue injury at the site of bleeding. Fig 8.3. 86-88 Electrocautery should be avoided at fresh staple lines. Hemostatic powders are another option, however, there are limited data on their use after bariatric surgery. Angiographic intervention can be considered, but the resulting ischemia is a concern in patients with new anastomosis. Stenosis is a common complication after bariatric surgery. Patients present with early satiety, nausea, vomiting, and dysphagia. Postprandial retrosternal or abdominal pain may also be present. In patients with history of RYGB, stenosis often occurs at the GJA, and rates of 1.5% to 7.3% 89-92 are reported after laparoscopic RYGB. Most stenosis at the GJA develops 4 to 10 weeks after surgery. In cases of stricture formation incited by ulcer or foreign material, presentation may be delayed for months or years. Less common sites for stenosis after RYGB include the jejunal anastomosis, sites of intestinal adhesions, and sites of passage through the mesocolon. Endoscopy is an excellent diagnostic tool because the etiology, e.g., foreign body, can often be identified, and therapy applied concurrently. By definition, stomal stenosis is present if the standard 9.5 mm endoscope cannot traverse the anastomosis. Treatment of stomal stenosis can be performed with a throughdoscope, TDS, balloon, Savary dilator, or electrosurgical incision. Balloon dilation is the most commonly used technique and is successful in more than 90% of cases. 91,92 Some patients require 2 or 3 procedures, which can begin postoperatively when symptoms begin and be repeated every 2 to 3 weeks. The balloon catheter should be advanced beyond the GJA, with care to avoid entry into the blind limb. A guide wire and / or fluoroscopic imaging can be used when observation of catheter advancement is suboptimal, or resistance is encountered. Once the balloon is fully outside the endoscope, it can be inflated so that its midpoint applies radial pressure into the stricture for at least 60 seconds, or until the balloon waste disappears on fluoroscopy. Although 20 mm diameter has been reported to be successful, the smallest effective dilation is preferred, 8 to 12 mm. A gradual approach to dilation over several sessions can reduce perforation risk, reported to be 2.1% to 5% 91,92, and decrease the possibility of overdilation with resultant weight regain. Suture material at the GJA may have to be removed to achieve successful dilation. 77 Other types of bariatric surgery also may be complicated by stenosis. Patients with a history of LAGB may have obstruction as a result of edema or excess tissue at the level of the band. There may be a fibrous reaction to the band. In these cases, endoscopic dilation can be attempted if stenosis persists despite complete Fig. 8.3 postoperative hemorrhage with hemostasis using endoscopic clips. Images courtesy Christopher C. Thompson, MD. 108 Part 2 Nutrition in Gastroenterology. Drainage of the band reservoir. Band removal, band replacement, or conversion to RYGB also may be considered if conservative measures are unsuccessful. Patients with history of SG may have stenosis at the gastroesophageal junction or at the incisura angularis. Serial endoscopic balloon dilation. Starting with a hydrostatic TDS balloon dilation can be attempted. Pneumatic dilation at the site of the stricture has been reported as well. 77,93 Another approach to stenosis is temporary covered metal stent placement for up to 8 weeks. Ultimately, conversion to RYGB may be required. 93 Foreign body complications. Foreign materials, e.g., sutures, staples, bands, are placed during bariatric surgery. The foreign material, with its subsequent inflammatory response, may result in pain, ulceration, and obstruction. Implanted foreign bodies, e.g., bands, mesh, can also erode or migrate. Fig. 8.4. Patients with chronic pain after bariatric surgery should undergo endoscopic examination with removal of visible retained foreign material. Foreign material has been associated with pain even when there is no adjacent visible inflammation. Traction on sutures or staples often reproduces pain. Ryu and colleagues demonstrated immediate symptomatic improvement in 71% of patients after foreign body removal. 94 Leaks and fistulae. A leak is caused by discontinuity of tissue apposition in the immediate postoperative period. The incidence of leak after bariatric surgery ranges from 1.7% to 2.6% after open RYGB, to 0.3% to 4.2% after laparoscopic RYGB, and 0.7% to as high as 5.1% after SG. 94-99 A recent review of the MSOQIP database revealed a leak incidence of 0.3% in 364,000 bariatric surgeries. 95 After RYGB, leaks can occur at several sites: the gastric pouch, GJA, jejunal stump, jejunal anastomosis, excluded stomach, duodenal stump, in resectional bypass, and blind jejunal limb, all of these should be considered when a leak is suspected. The most common sites are the gastrojejunal, 68%, or jejunal, 5%, anastomosis, or at gastric pouch staple lines, 10%, an additional 14% involve multiple sites. Some leaks may be especially challenging to localize, such as those from the excluded stomach, because routine endoscopy and UGI series may be normal. Incidence of leak is highest in patients with divided RYGB. The risk of chronic gastrogastric fistula is highest when the pouch and excluded stomach are contiguous, as with the open surgical approach, Fig 8.5. In patients with SG, most leaks occur in the proximal third of the stomach near the gastroesophageal junction, 85.7%, while the remainder are found in the distal third. Leaks are associated with a mortality rate of 3.3% to 14.96%. Other than PE, they are the most serious life-threatening complication of bariatric surgery. In addition to doubling the risk of mortality, leaks result in a six-fold increase in hospital stay. Patients who develop a leak are at increased risk for wound infection, sepsis, respiratory failure, renal failure, thromboembolism, internal hernia, and SBO. Leaks often present without fever, leukocytosis, or pain. The most common reported sign of a leak is tachycardia, 97% present in 72% to 92% of patients. Other symptoms and findings include nausea and vomiting, 81%, fever, 62%, and leukocytosis, 48%, any of which demand a high suspicion for leak in patients after bariatric surgery. Objective findings include increased drain output, as well as elevated CRP greater than 22.9 mg/dl 2 days after surgery, sensitivity, 1.00. This differs from chronic gastrogastric fistulae, which have a more indolent course and typically manifest with acid reflux, abdominal discomfort, and weight regain. As gastric acid can flow into the pouch via a gastrogastric fistula, RYGB patients with heartburn, acid reflux, or anastomotic ulcer should be evaluated for fistula formation. 98 As endoscopic management techniques for the bariatric surgery patient gain acceptance, they are being used earlier in the postoperative course. Dilation of distal stenoses should be performed. Exclusion techniques, such as stent placement, can occlude or bypass leaks. Leaks and fistulae also can be closed with clips, suturing devices, or sealants. Stent placement to exclude the leak from the GI tract is the endoscopic technique supported by the most substantial body of evidence, Fig 8.6. Stent placement allows the leak to heal while enteral nutrition is resumed, potentially accelerating recovery and avoiding the need for parenteral nutrition. Peritoneal Fig 8.4 Band erosion. From L. Hayek K., Timratana P., Breathour S.A., Chand B. Complete endoscopic/transgastric retrieval of eroded gastric band, description of a novel technique and review of the literature. SURG Endosc 2013, 27:2974-9. Fig 8.5 Gastrogastric fistula. Images courtesy Christopher C. Thompson, M.D. Chapter 8 Surgical and Endoscopic Treatment of Obesity 109 8 Contamination is decreased, and improvement in abdominal pain may follow. Self-expanding metal stents have been used successfully, employing a forward-viewing endoscope and fluoroscopic guidance. A meta-analysis of stent placement for treatment of acute leaks after bariatric surgery by Pulley and colleagues found a pooled proportion for successful leak closure, defined as radiologic evidence of leak closure after stent removal, of 87.8%, 95% CI, 79.4% to 94.2%, 0.99 Most leaks closed with one treatment, but restenting was reported in 4 of 7 studies. 9% of patients had failure to respond and required revisional surgery. Stents were extracted between 4 and 8 weeks in the majority of studies. Stent migration was reported in 16.9%, 95% CI, 9.3% to 26.3%, of cases. Endoscopic clips also have been used to close fistulae and leaks. Clips are used to approximate the tissue surrounding the defect to effect closure and, therefore, are best deployed perpendicular to the long axis of the defect. Thermal ablation or mechanical scraping of the tissue around the edges of the defect before clip deployment results in a more resilient seal. The over-the-scope clip, padlock, US endoscopy, or OTSC, Ovesco endoscopy AG, Tübingen, Germany, is a nitinol clip placed on a cap at the endoscope tip. A tissue anchor and twin grasper instrument are available and may be helpful in clip placement. Unlike clips inserted through the endoscope, which oppose mucosa, the OTSCs can perform full-thickness apposition. Case series of GI tract fistula closure have shown success rates of 72% to 91%. 0.98, 100 to 100, and 3 other small series have shown fibrin glue and various fistula plugs also to be effective. 104 Pancreaticobiliary disease. Endoscopic management of pancreatic and biliary disease with EUS and ERCP presents a unique challenge in patients with altered anatomy. Patients with LAGB, SG, and VBG are usually able to have successful EUS or ERCP with a side-viewing endoscope just as patients with normal anatomy. Unfortunately, rapid weight loss may induce a lithogenic state. Nearly 50% of patients will develop gallstones or sludge after RYGB, and over 25% may undergo cholecystectomy. Patients with a history of RYGB and BPD and DS often require special tools and procedures to complete ERCP. While the papilla can be reached with balloon-assisted enteroscopy in most cases of RYGB, optimum alignment for cannulation and, if desired, placement of a protective pancreatic stent is not always possible. This has led to various approaches to access the diverted stomach and completion of ERCP with a side-viewing duodenoscope. 105,106 Prior to ERCP, preparation should include verification of need for ERCP as well as characterization of anatomy and pathology via cross-sectional imaging. Some patients have anatomy that is not amenable to a purely endoscopic approach, even via device-assisted enteroscopy. Typically, if surgery is planned, ERCP can be performed concurrently with laparoscopic assistance and access to the stomach. If surgery is not planned, then the options for accessing the major papilla to perform ERCP include laparoscopic-assisted ERCP, enteroscopy-assisted ERCP, direct biliary intervention by EUS, and the creation of a fistula between the gastric pouch and the bypassed stomach using EUS and a lumen-opposing fully covered metallic stent. EUS-directed transgastric ERCP is a transluminal approach to the bypassed stomach that can be completed in a single setting using a fully covered lumen-opposing metallic stent. 107,108 Weight regain and dilated gastrojejunal anastomosis. Bariatric surgery is effective in achieving durable weight loss, but weight regain postoperatively is a potential problem. It reintroduces the risks of obesity-associated diseases and has significant impact on quality of life. Although initial weight loss after bariatric surgery is often dramatic, a weight plateau is typically achieved in 1 to 2 years. A recent analysis from the Veterans Affairs healthcare system followed 1,787 patients after bariatric surgery with 81.9% follow-up at 10 years. The authors found that at 10 years after RYGB, 28.2% of patients had less than 20% total body weight loss, %TBWL, and 3.4% were within 5% of their baseline weight. 109 Given the large number of patients undergoing bariatric surgery, demand for therapy to address weight regain will continue to increase. Weight regain after bariatric surgery is likely multifactorial. In a systematic review, these factors included nutritional noncompliance and grazing eating patterns, neuroendocrine metabolic regulation, mental health issues, binge eating and substance abuse, physical inactivity, and anatomic issues. 110 After RYGB, weight regain can be seen with gastrogastric fistula, and it has been shown that larger pouch size and GJA diameter are associated with postoperative weight regain. 111,112 Similarly, weight gain can occur with SG, and in some cases is related to dilation of the sleeve. 113 Surgical revision to address these issues is problematic because complication rates are higher than with the primary procedures. 114,115 Medications have also been used to treat weight regain. However, in a retrospective analysis, only one medication used off-label, topiramate, demonstrated significant weight loss, and only 56% of the entire cohort with inadequate weight loss or weight regain achieved 5% or more of their post-surgical total weight loss. 116. Endoluminal therapy for RYGB, however, has shown promise in effectively addressing weight regain with lower morbidity. Video 8.1. Fig 8.6a, gastrocutaneous leak, arrow. B. Leak treated by stent placement. Images courtesy Christopher C. Thompson, M.D. AB 110 Part 2 Nutrition in Gastroenterology. Transoral outlet reduction, TOR, has been studied on multiple platforms. Fig 8.7. A randomized double-blinded trial compared TOR using the barred endocinch with a sham procedure in 77 patients with GJA diameter wider than 20 mm. 117 GJA diameter was reduced to less than 10 mm in 89.6%, with no perforations and an adverse event rate that was similar to that of the sham group. 96% of revised patients had weight loss or stabilization in the following 6 months. Mean weight loss in the revised group was 3.9% compared with 0.2% in the sham group, p equals 0.014, in an intent-to-treat analysis. The Apollo overstitch device, Apollo endosurgery, Austin, TX, also has been shown to be effective at TOR by placing full-thickness sutures at the GJA. 118 A recent meta-analysis of 3 studies in patients who had weight regain after RYGB found that 77% to 100% stopped gaining weight and that weight loss at 12 months was 5.83 plus or minus 11 kg to 10.5 plus or minus 12.5 kg. 119 Endoscopic treatments for obesity. Endoscopic bariatric therapy, EBT, for the primary treatment of obesity has rapidly progressed in recent years, with multiple devices approved by the FDA and many more therapies currently undergoing investigation. Although bariatric surgery is effective, patients are eligible only if they have obesity class 3, BMI 40 kg/m2, or obesity class 2, BMI 35 to 39.9 kg/m2, with significant associated comorbid illness. Not only do many patients not meet this criterion, but less than 2% of the population who meets this criterion undergoes bariatric surgery per year. 120 The reasons for the low surgical rates are likely multifactorial, but highlight the need for additional treatment options. Lifestyle therapy should be considered the cornerstone for any obesity treatment plan but has limited effectiveness and durability on its own. Recent advances have also been made in obesity pharmacotherapy, and demonstrate modest improvement in weight loss over lifestyle therapy alone in randomized controlled trials. 121 Real-world clinical outcomes, however, may not demonstrate similar weight loss 122 or compliance with medication as seen in randomized controlled trials. 123 EBTs approved to date have demonstrated significant weight loss compared with lifestyle therapy alone in multi-center randomized controlled trials, which will be reviewed in this section. Although weight loss is less than is seen with bariatric surgery, risk of serious adverse events is also less than seen in bariatric surgery. Moreover, many of the devices have been approved for use in patients with a BMI between 30 and 40 kg/m2, increasing treatment options in patients who would not qualify for bariatric surgery. EBTs can be divided into gastric therapies and small bowel therapies. Gastric therapies are devices or procedures that are placed or performed in the stomach. Small bowel therapies are devices or procedures that are placed or performed in the small bowel. Two distinguishing features of gastric and small bowel endoscopic bariatric therapies are their procedure or device placement location and weight loss independent effects. Although no small bowel therapies have been approved yet by the FDA, data support both weight loss dependent and weight loss independent effects on metabolic outcomes. At this time, there are data to demonstrate weight loss dependent effects on metabolic outcomes, but no data to suggest that gastric therapies have weight loss independent effects on metabolic outcomes. As of the writing of this chapter, the only EBTs that have been approved by the FDA or are currently performed in the USA are gastric EBTs, and they will be the focus of the remainder of this section. Evaluation and selection of endoscopic bariatric therapy candidates. In 2015, the ASGE published a position statement regarding EBTs in clinical practice. 124 The ASGE position statement recognized the clinical practice guidelines for the perioperative nutritional, metabolic, and non-surgical support of bariatric patients undergoing bariatric surgery, updated in 2013 by the American Association of Clinical Endocrinologists, the Obesity Society, and the American Society for Metabolic and Bariatric Surgery. 125, but acknowledged that these guidelines may not be applicable to all EBTs. In contrast to bariatric surgical procedures, EBTs are minimally invasive procedures, which may be short-term, reversible, or with minimal long-term changes to anatomy. The reversibility, safety profile, and reduced risk of anesthesia have resulted in reduced preoperative evaluation criteria for device placement. At a minimum, the ASGE position statement recommended performing a medical history, physical exam, screening for obesity-related diseases, and commitment to lifestyle change, nutrition history, and routine laboratory testing. Indications for EBTs vary based on the device and the study population used for FDA approval. In some cases, data on safety and efficacy are available for people outside of the FDA-labeled indications. 126,127 but any use outside FDA labeling is considered off-label use. AB Fig 8.7 Endoscopic suturing for dilated gastrojejunal anastomosis. Panel A before suturing and Panel B after argon plasma coagulation and suturing with a purse string technique. Images courtesy Shelby Sullivan, MD. Chapter 8 Surgical and Endoscopic Treatment of Obesity. 111 Endoscopic bariatric therapies. Currently 8 performed in the USA. 4 gastric EBTs have been approved by the FDA for the indication of weight loss. These include 3 intragastric balloons, IGBs, and 1 device for aspiration therapy. IGBs are space-occupying devices which are inflated in the stomach with either saline or nitrogen mixed gas and removed endoscopically after 6 months. These devices promote weight loss through both taking up space in the stomach and, in the case of the fluid-filled balloons, also result in slowing of gastric emptying. 128 Other mechanisms may also promote satiety, but further research is needed in this area. Table 8.1 includes all of the currently approved IGB and their FDA indications. Aspiration therapy is performed with a specialized endoscopically placed percutaneous gastrostomy tube with attachable components to facilitate removal of a portion of the gastric contents after a meal. Fig 8.8. Patients not only remove a portion of the calories they consumed in the meal, but the device also promotes changes in eating behaviors, which result in decreased consumption of food at mealtime. 129 One additional therapy, endoscopic sleeve gastroplasty, in which a series of sutures endoscopically placed in the gastric body changes the shape of the stomach to resemble a tube, is currently being performed in the USA. This therapy decreases gastric volume, resulting in satiety, and may also delay gastric emptying. Although this has only been studied in 4 patients. 130 It is important to note that this procedure is not FDA approved, but is performed using a device which has 510(k) clearance from the FDA for the general purpose of tissue apposition in the GI tract. Intragastric balloons. 2 of the currently FDA-approved IGBs are filled with saline and require endoscopic placement under direct visualization. The single fluid-filled balloon, Orbera gastric balloon, Apollo Endosurgery, Austin, TX, is delivered on a catheter, and is placed without a guide wire, similar to an orogastric tube. Once in the stomach, the balloon is filled with saline under direct visualization to a volume between 400 and 700 ml. After filling is complete, the catheter is pulled against the gastroesophageal junction to detach the balloon, and then removed out through the patient's mouth. After 6 months, a repeat endoscopy is performed during which a catheter containing a beveled needle is used to puncture the balloon. The needle is then removed, the catheter is advanced into the balloon, and the fluid is aspirated. Once the balloon is deflated, a 2-prong grasper is used to secure the balloon, and the balloon is pulled out through the patient's mouth. The dual saline-filled IGB, reshaped gastric balloon, Apollo Endosurgery, Austin, TX, has recently been purchased by the same manufacturer as the single fluid-filled balloon but will no longer be manufactured. It is delivered into the body of the stomach over a guide wire placed during the initial portion of the endoscopy. Once in place, the guide wire is removed and the proximal balloon is filled with either 375 ml or 450 ml of saline mixed with methylene blue. Once the balloon inflation is complete, the balloon is sealed with 6 ml of mineral oil. The process is repeated for the distal balloon. Once completed, the catheter is pulled against the gastroesophageal junction to detach the balloons from the delivery catheter, which is then pulled out through the mouth. After 6 months, a repeat endoscopy is performed during which a catheter containing a non-beveled needle is used to bore a hole in the balloon. The needle is retracted, the catheter is advanced into the balloon, and the fluid is aspirated. The process is repeated for the second balloon. Once both balloons are deflated, a 15 mm rat-tooth alligator forceps is used to rip a hole in each balloon and a hexagonal snare is used to secure the proximal tip of the device. The device is then pulled out through the patient's mouth. The swallowable gas-filled IGBs, Oberlin Balloon System, Oberlin Therapeutics, Carlsbad, CA, each are swallowed in a capsule that is tethered to a catheter with a hydrophilic coating. Capsule transit into the stomach is verified by imaging with fluoroscopy or digital X-ray, and a pressure drop on the gas dispenser pressure sensor attached to the catheter outside of the patient's mouth indicates when the balloon is unfolding in the unconstrained space of the stomach. The valve regulating flow from the gas canister to the balloon is then opened and gas flows into the balloon to a final pressure of 9 to 13 kPa and volume of 250 ml. The catheter is then ejected off of the balloon with pressure from 1.5 ml of water injected into the catheter. This process is repeated at 2 weeks and 8 weeks from the first balloon administration in order to administer all 3 balloons. 6 months after the first balloon administration was performed, an endoscopic procedure is performed to remove the balloons. Each balloon is deflated with an injector needle attached to suction and then grasped with a 15 mm rat-tooth alligator forceps for removal out the mouth. The process is repeated for the remaining 2 balloons. Aspiration therapy device. The implantable component of the aspiration therapy device, Aspire Assist, Aspire Bariatrics, King of Prussia, PA, is a gastrostomy tube made of medical-grade silicone that is placed with standard pull-peg tube placement technique. 131 At the time of placement, an external pumper is placed, and the patient returns 1 to 2 weeks later for conversion of the external portion of the gastrostomy tube to a skin port, which is used for aspirating. As with traditional peg tube placement, patients should receive 4 antibiotics 30 minutes before the procedure and should also have an additional 24 hours of oral antibiotic prophylaxis. Endoscopic sleeve gastroplasty. Endoscopic SG is performed using a suturing device fixed to the distal tip of the endoscope. Currently the only marketed suturing device is the Overstitch, Apollo Endosurgery, Austin, TX. A standard upper endoscope is first used to evaluate the stomach and then place marks on the anterior and posterior walls of the stomach where sutures will be placed. The scope with the attached suturing device is inserted with or without an overtube into the stomach. Starting on the anterior wall in the distal gastric body adjacent to the incisura, tissue is grabbed with a tissue helix and pulled toward the scope to allow for the needle driver to pass the needle through the tissue. This process is repeated for 5 to 8 bites in a U or Z-shaped pattern. The needle is released from the needle exchange catheter, and a cinch is placed on the opposite end of the suture, bringing the tissue together between the needle and the cinch. Once desired tightening is achieved, the suture is cut and the process is repeated moving proximally in the stomach until the proximal gastric body is reached. Fig 8.9. Some practitioners place a second row of sutures to reinforce the first set of sutures placed, but this is variable. Typically, 4 antibiotics are given at the time of procedure. Endoscopic bariatric therapy complications. Intragastric balloons. Adverse events, Es, are common with IGB, but most non-serious Es are mild to moderate in severity. Table 8.2 shows the non-serious Es reported in the USA multi-center pivotal trials used for FDA approval. 132-135 The most common Es for the fluid IgBs were nausea and vomiting. Vomiting was significantly less in the swallowable gas-filled IgB system. These symptoms are associated with accommodation of the stomach to the IgB and generally resolve within the first few days to weeks of therapy. Gastric ulceration occurred at a rate of 35% in the dual IgB pivotal trial, which was significantly higher than the other FDA-approved IgBs at 0% and 0.9% respectively for the single fluid-filled IgB and the swallowable gas-filled IgB system. This 112 Part 2 Nutrition in Gastroenterology Table 8.1 FDA-approved intragastric balloons device image FDA status Reshape dual balloon system Reshape Medical, San Sealment, CA approved for BMI 30 to 40 kg/m2 with 1 obesity-related comorbidity Orbera intragastric balloon, Apollo Endosurgery, Austin, TX approved for BMI 30 to 40 kg/m2 Chapter 8 Surgical and Endoscopic Treatment of Obesity 113 8 Device image FDA status Obalon Balloon System, Obalon Therapeutics, Carlsbad, CA approved for BMI 30 to 40 kg/m2 Images from Abu Daya BK, Edmundao's SA, Jonal Agata S, ETAL Endoscopic Bariatric Therapies. Gastrointestinal 2015, 81, 51073-86, with permission, and Sullivan S., Swain J., Woodman et al. Randomized sham-controlled trial of the 6-month swallowable gas-filled intragastric balloon system for weight loss. SURG OBS Relat Dis 2018, 14, 12-1876-89, with permission. 114 Part 2 Nutrition in Gastroenterology Difference, however, was attributed to a distal tip design which was modified during the trial, resulting in a smaller-sized ulcer and a reduction in incidence to 10%. 136 A subsequent publication of a retrospective analysis of 202 patients treated clinically at 7 different centers in the USA found an ulceration rate of 0.9% and an erosion rate of 13.8% at the 6-month removal period. GERD occurred at a rate of 30% in the single fluid-filled IgB pivotal trial, higher than the other two IgBs 132 which was significantly higher than a GERD rate of 6.8% for the dual fluid-filled IgB and a composite of 16.9% for both GERD and dyspepsia for the swallowable gas-filled IgB system. No retrospective analysis of clinically treated patients has been published to date for the swallowable IgB system. Early removal rates, symptom-related and non-symptom-related, of the IgBs in the USA Pivotal and USA Clinical Case Series were 15% 136 and 6.4% 137 for the dual fluid-filled IgB, 18.8% 138 and 16.6% 139 for the single fluid-filled IgB. Early removal rates for the swallowable gas-filled IgB system have not yet been published. Serious Es occurred at a rate of 10.6% in the dual fluid-filled IgB, combined randomized and crossover cohort combined, 133,136 10% in the single fluid-filled IgB 132,138 and 0.3% in the swallowable gas-filled IgB system, randomized and crossover cohort combined, 134 in the USA pivotal trials, which led to FDA approval of these devices, see Table 8.2. The most common serious Es for both the dual and single fluid-filled IgBs were due to accommodative symptoms, nausea, vomiting, and abdominal pain, with or without dehydration, 75% and 71% respectively for the dual and single fluid-filled IgBs. Other serious Es for the dual fluid-filled IgB included, contained esophageal perforation, esophageal tear, UGI hemorrhage, gastric ulcers, pneumonia, and muscle pain. Other serious Es for the single fluid-filled IgB included gastric outlet obstruction, gastric perforation with sepsis, aspiration pneumonia, and abdominal cramping with an IgB containing infected fluid. Only one serious AE occurred in the swallowable gas-filled IgB system pivotal trial, which was a bleeding ulcer in a patient on high-dose NSAIDs. In the subsequent USA retrospective analysis of patients treated with the single fluid-filled IgB, non-serious Es were not systematically recorded. However, 7% of patients were noted to have esophagitis after balloon removal, 3% at baseline, 0.5% had an ulcer, and 0.5% had an esophageal tear. 8% of patients required outpatient 4 fluids for dehydration after placement, 4% required hospitalization after IGB placement, and 1% required hospitalization after balloon removal. 139 Early IGB removals occurred in 16.6% of patients for nausea, n equals 11, vomiting, n equals 19, abdominal pain, n equals 4, reflux, n equals 4, a combination of symptoms, n equals 2, and by patient request, n equals 13. Additionally, in clinical series of the single fluid-filled IGB, 1 aspiration event was noted and 1 IGB deflation occurred, although this balloon passed out of the GI tract naturally. The most common non-serious reported in the dual fluid-filled IGB were esophageal or gastric superficial tear on placement, 8.4%, and removal, n equals 5, nausea, 73.8%, vomiting, 49%, and post-procedure pain, 25.2%. Early balloon removal was performed in 6.4% of patients. A tube, a skin port, companion connector, patient line, drain tube, reservoir. B Fig 8.8 Components of the Aspire Assist System, Panel A, Permanent Components, Panel B, Components only used during aspiration. From Sullivan S. Aspiration Therapy for Obesity. Gastrointestinal Endoscopy Clinics of North America. 2017, 27, 227788, with permission. AB Fig 8.9 Endoscopic sleeve gastroplasty. Panel A, gastric body before the procedure, Panel B, gastric body after the procedure, images courtesy of Shelby Sullivan, MD. Chapter 8 Surgical and Endoscopic Treatment of Obesity 115-8 For symptoms, n equals 10, and spontaneous deflation occurred in 4 patients, 2 of whom required surgical removal of the balloon because it had migrated into the small intestine. An additional deflation was found on removal in a patient with a history of motor vehicle accident with blunt force trauma to the abdomen 1 week prior to removal. 137 One clinical registry of prospectively collected data has been published for the swallowable gas-filled IGB system, including 1,343 patients in the safety analysis. Non-serious occurred in 14.22% of patients, the most common of which was abdominal pain, 5.29%, nausea, 4.69%, and vomiting, 2.31%. 2 serious occurred, including dehydration requiring 4 fluid administration in 1 patient, 0.07%, and 1 gastric perforation treated with removal of the balloons and surgical repair of the perforation, 0.07%, 0.140. Although not seen in any of the pivotal trials or clinical registries, the FDA published an update to a letter to healthcare providers on June 4, 2018, which described 12 deaths from fluid-filled IGBs since its approval in the USA, with 7 of the 12 deaths occurring in the USA. Data on the root cause of these deaths are still unclear as of the writing of this chapter. Other events determined to be related to the fluid-filled IGBs, but not previously reported in the trials, included hyperinsufflation and pancreatitis. The rates of these remains low, with the USA mortality rate from the dual and single fluid-filled IGB reported by the manufacturers as 0.06% 141 and 0.036% 142 respectively. No reports of deaths attributable to the swallowable gas-filled IGB system have been reported in the USA as of the writing of this chapter. Aspiration therapy. 2 randomized controlled trials have been performed in the USA comparing aspiration therapy and lifestyle therapy, but only included 1 small single-center pilot study and 1 large multi-center trial. A previous version of the device with significant difference in the gastrostomy tube from the current gastrostomy tube was used in the pilot study and was associated with abdominal discomfort greater than 4 weeks after gastrostomy tube placement in all patients in the study. Treatment group n equals 10. Which prompted a design change in the gastrostomy tube. 129 In the multi-center US trial, treatment group n equals 111, Peristomal granulation tissue was the most common AE at 40.5%. Other non-serious AEs that occurred in greater than 5% of patients included abdominal pain less than 4 weeks after gastrostomy tube placement 37.8%, nausea/vomiting 17.1%, peristomal irritation 17.1%, intermittent abdominal discomfort 16.2%, possible or definite peristomal bacterial infection 13.5%, abdominal pain greater than 4 weeks after gastrostomy tube placement 8.1%, dyspepsia 6.3%, and peristomal inflammation 5.4%. 5 serious AEs in 4 patients, 3.6%, were reported including severe abdominal pain, 2 admissions in 1 subject, peritonitis, prepyloric ulcer, and a gastrostomy tube replacement due to a malfunction. 143 Endoscopic sleeve gastroplasty. No randomized controlled trials of endoscopic sleeve gastroplasty have been performed. The first in-man study with 3 study phases of procedure development included a total of 22 patients in the second phase, sites in the USA and Dominican Republic, and 77 patients in the third phase, sites in the USA, Dominican Republic, and Spain. AEs included frequent nausea, vomiting, and transient epigastric pain in the first week after the procedure, but no serious AEs were reported in either cohort. 144 Two large retrospective analyses, N equals 248 and N equals 112, which included sites both in the USA and outside of the USA, and reporting AEs have been published. 145,146 Non-serious AEs were not systematically recorded in either study, but nausea, vomiting, and abdominal pain were described in a large number of patients in one series. 146 5 serious AEs, 2%, occurred in the larger retrospective analysis, including 2 perigastric inflammatory fluid collections treated with percutaneous drainage and antibiotics, extragastric hemorrhage due to splenic laceration, pulmonary embolism, and pneumoperitoneum/pneumothorax. The manuscript does not report on hospitalizations for accommodative symptoms. 145 In the second retrospective series, only 3 serious AEs occurred requiring hospitalization, including 2 patients with bleeding. In 1 patient, low molecular weight heparin and warfarin were started on day 1 after the procedure, that required endoscopic therapy in 1 case. 1 perigastric fluid collection also occurred, managed with oral antibiotics as an outpatient. 146 Nutritional deficiencies. Nutritional deficiencies have not been reported as a consequence of IGBs or endoscopic sleeve gastroplasty. A pilot study for aspiration therapy reported on iron and vitamins D and B12, with 4 of 10 subjects requiring iron supplementation, 3 of 10 subjects requiring vitamin D supplementation, due to low vitamin D at baseline, and 1 of 10 requiring B12 supplementation, which maintained normal concentrations of these micronutrients. Potassium supplements and PPI therapy were given to all subjects as part of the Protocol 129. This was not continued for the multi-center USA randomized controlled trial, and only 4 of 111 participants in the aspiration therapy group required supplementation during the first 52 weeks of the trial. 143 Outcomes. Intragastric balloons. Multi-center randomized controlled trials have been performed for all 3 FDA-approved IGBs. All of the studies used a moderate intensity lifestyle therapy, between 6 and 13 sessions, for the first 6 months. However, only 2 of the balloons, the dual fluid-filled IGB and the swallowable gas-filled IGB system, had a sham control group. 134,136 The effect of knowledge of group assignment in a weight loss device study has been shown to increase weight loss by approximately 40%. 147 This is consistent with weight loss differences seen in the active groups of the IGBs with randomized sham-controlled trial designs. The open-label randomized controlled trial of the single fluid-filled IGB demonstrated 35% to 40% more weight loss, Table 8.3. Moreover, clinical effectiveness data from both the dual fluid-filled IGB and single fluid. Table 8.2 Non-serious adverse events in the intragastric balloon USA multi-center trials. Adverse event reshape, %. Orbera, %. Obolin, %. Vomiting 86.7, 86.8, 17.3, nausea 61.0, 75.6, 56.0, abdominal pain 54.5, 57.5, 72.6, gastric ulcer 35.2, asterisk 0.9, dyspepsia 17.8, 21.3, 16.9, eructation 16.7, 24.4, 9.2, abdominal discomfort 13.3, 6.30, abdominal distension 11.0, 17.5, 14.6, erosive gastritis 9.1, 0.6, 7.1, GERD 6.8, 30.0, C. dyspepsia, erosive esophagitis 0.4, 0.6, 1.8, constipation 5.3, 2.7, diarrhea 3.0, 13.1, 8.3, asterisk after design modification of the distal tip of the reshaped balloon, the ulcer rate decreased to 10%. Composite of dyspepsia and GERD. Composite of erythema, erosion, inflammation, or polyp. From Sullivan S., Edmund Dowes S.A., Thompson C.C. Endoscopic Bariatric and Metabolic Therapies, New and Emerging Technologies. Gastro 2017, 152:1791-801, with permission. 116 Part 2 Nutrition in Gastroenterology IgB registries and the swallowable gas-filled IgB system registry demonstrate higher weight loss than was seen in the pivotal trials. In the dual fluid-filled IgB registry, 202 patients, age 47.8 plus or minus 10.8 years, female 83.2%, BMI 36.7 plus or minus 6.6 kg/m2, underwent balloon placement. Weight loss was 11.4 plus or minus 6.7% TBW at 6 months, but data were only available for 101 patients. 137 in the single fluid-filled IgB registry, 321 patients, age 48.1 plus or minus 11.9 years, female 80%, BMI 37.6 plus or minus 6.9 kg/m2, underwent balloon placement. Weight loss was 11.8 plus or minus 7.5% TBW at 6 months, but data were only available for 199 patients. 139 in the swallowable gas-filled IgB registry, 1,387 patients initiated therapy, with 3.2% of patients excluded from the final analysis, N equals 36 without a final weight and N equals 8 with a starting BMI 25 kg/m2. 1,343 patients were included in the intention to treat analysis, age 45.7 plus or minus 10.8 years, female 78.6%, BMI 35.4 plus or minus 5.4 kg/m2, which was defined as having at least one balloon for at least 1 day, and 82.1% of patients, N equals 1,103, were included in the completer analysis, which was defined as a total of exactly 3 balloons administered for at least 20 weeks. Weight loss at 6 months was 9.9% plus or minus 6.2% TBW in the completer analysis and 9.2% plus or minus 6.3% TBW in the intention to treat analysis. An analysis including only the on-label population, BMI 30 to 40 kg/m2 with 3 balloons for at least 20 weeks, N equals 787, demonstrated weight loss of 10.0 plus or minus 6.1% TBWL. 140 Aspiration therapy. 2 randomized controlled trials in the USA have demonstrated weight loss superiority of aspiration therapy plus lifestyle therapy compared with lifestyle therapy alone. In a pilot study, 4 patients in the lifestyle therapy only group, age 45.3 plus or minus 2.8 standard error of the mean SEM years, female 100%, BMI 39.3 plus or minus 1.1 SEM kg/m2, and 10 patients in the aspiration therapy plus lifestyle therapy only group, age 38.7 plus or minus 2.3 SEM years, female 100%, BMI 42.0 plus or minus 1.4 SEM kg/m2, completed 1 year of therapy. The percent TBWL in the lifestyle therapy only group at 1 year was 5.9 plus or minus 5.0% compared with 18.6 plus or minus 2.3% in the aspiration therapy plus lifestyle, p equals 0.021. 7 subjects in the aspiration therapy plus lifestyle therapy arm completed an additional year of therapy with 20.1 plus or minus 3.5% TBWL at the end of year 2.132 in the pathway study. The modified intention to treat analysis included 60 patients in the lifestyle therapy only group, age 46.8 plus or minus 11.6 years, female 88.3%. BMI 40.9 plus or minus 3.9 kg/m2, and 111 patients in the aspiration therapy plus lifestyle therapy group, age 42.4 plus or minus 10.0 years, female 86.5%, BMI 42.0 plus or minus 5.1 kg/m2. The percent TBWL in the lifestyle therapy only group compared with the aspiration therapy plus lifestyle therapy group was 3.5 plus or minus 6.0% versus 12.1 plus or minus 9.6% respectively, p 0.001 for the modified intention to treat analysis. This compares with 4.9 plus or minus 7.0% and 14.2 plus or minus 9.8% for the lifestyle therapy only. N equals 31, and aspiration therapy plus lifestyle therapy, N equals 82, groups in the subjects that completed 1 year of therapy, p 0.001.14355 of the subjects in the aspiration therapy plus lifestyle therapy group continued therapy beyond 1 year with 42 subjects, 22 subjects, and 15 subjects completing 2, 3, and 4 years of therapy with 15.3 plus or minus 8.8%, 16.6 plus or minus 10.5%, and 18.7 plus or minus 11.7% TBWL respectively. 148 Endoscopic sleeve gastroplasty weight loss data from the first reported multi-center case series included 248 patients, age 44.5 plus or minus 10 years, female 73%, BMI 37.8 plus or minus 5.6 kg/m2. Weight loss was 15.2% TBW, 95% CI 14.2 to 16.3, at 6 months with 87% of patient follow-up and 18.6% TBW, 95% CI 15.7 to 21.5, at 24 months with only 62% patient follow-up. 145 in the series by Sartor et al., 112 patients were included, age 45.1 plus or minus 11.7 years, female 69%, and BMI 37.9 plus or minus 6.7 kg/m2. Weight loss was reported in 61.6% of the patients with 14.9 plus or minus 6.1% TBW at 6 months. 146 weight loss was also reported in a multi-phase first-in-man series with USA patients included in phase 2, N equals 22, age 39.2 plus or minus 1.2 years, female 91%, BMI 34.3 plus or minus 1.0 kg/m2. And phase 3, N equals 77, age 41.3 plus or minus 1.1 years, female 77%, BMI 36.1 plus or minus 0.6 kg/m2. 144 weight loss was reported in 91% of the phase 2 subjects with 17.3 plus or minus 2.6% TBWL at 12 months, and weight loss was reported in 57% of the phase 3 subjects with 17.4 plus or minus 1.2% TBWL at 12 months. No randomized controlled trials of ESG have been performed to date. Obesity in the USA is often unfairly stigmatized and attributed to careless eating habits or lack of exercise. In reality, causes of obesity are multifactorial, with issues that include genetics, physiology, socioeconomic status, level of education, access to healthful foods, and awareness of how food directly impacts health. The rapid growth of the obesity epidemic must be addressed in such a way as to achieve more immediate outcomes. Surgical treatment of morbid obesity is safer and more effective than ever. Bariatric surgery has become a routine component of general surgery training and currently represents the fastest growing area in surgical training programs. Endoscopic bariatric therapies are new therapies with proven safety and effectiveness. Although these procedures, on average, produce less weight loss than bariatric surgery, they are also lower risk and provide important treatment options for patients with obesity. Moreover, endoscopic management of bariatric surgical complications continues to advance, with more complications managed without the need for additional surgery. Healthcare providers must work together to optimally support and care for this population, whether patients are working independently to lose weight, considering weight loss endoscopic or surgical procedures, or have undergone weight loss endoscopic procedures or surgery. Weight loss endoscopic procedures and surgery are most effective with proper patient selection and an appropriately trained procedural team. While risks exist, weight loss surgery and endoscopic bariatric therapies are potentially life-saving interventions in the right patients and in the right hands.